Hi, everyone. Welcome. I know people are trickling in um, this afternoon, morning, evening, depending where you're joining today. We're very excited to have Dr. Margaret Crane joining us today, who I will let introduce herself when she begins her presentation. And this is a topic that has come up a lot across discussions and across our community around understanding and exploring different strategies for estimating the cost of implementation activities. So we're going to walk away with some helpful and practical resources and ideas to hopefully take and explore further beyond today's webinar and think about how this can apply to your projects. So I see we still have some people joining in, but for the sake of time, and I know we've got a really great discussion today, we will continue on. Okay, so June here in Canada is National Indigenous History Month. And this was appointed and really recognized by the Government of Canada back in 2009 and is really an opportunity for us to reflect, celebrate the culture, history, knowledge, traditions of First Nations, Métis, and Inuit, and also to think about as individuals, as institutions, as organizations, how we can reflect on and also confront and challenge the ongoing health inequities and disparities that are connected to colonialism. So this month we can think about there's lots of different opportunities for learning always, but in particular this month. And just put on the slide here two examples that I've been exploring recently: the National Collaborating Center for Indigenous Health. And they have amazing resources, amazing webinars, as well as the Hearts-Based and Education Anti-Colonial Learning Healthcare Series. I don't know if anyone has seen that previously. They have brilliant arts-based different strategies and approaches that are really around decolonizing healthcare and research based on different categories. Whether that's anti-Indigenous racism. I was exploring one the other day around mental ableism, and yes, highly recommend. And if there's any resources, books that or videos that you've been looking at recently, please feel free to share those in the chat. So my name is Vanessa. I am the KBH Implementation Community Facilitator, or one of our co-facilitators. And as KBH and ChildBright are national in scope and reach, we give gratitude to the many lands and acknowledge the traditional territories that we have the privilege to work and operate on. Today, I'm calling in from Treaty 13 and Williams Treaties territory, which is the city of Toronto, the eastern part, which we call Scarborough now. And if you're curious and interested in learning more about your lands and the treaties, I encourage you to take a look at the link on the slide, and there's other resources that you can take a look at, and we're happy to share as well. So those of you who've attended this webinar, you've seen these slides before. For those who are new, welcome. Our implementation community is really about building connection, community, and capacity in the field of implementation science for those who particularly work in the neurodisability space. And so that's done through these public webinars and knowledge sharing, as well as our smaller community chats that are really focused on resource sharing, problem solving, and getting together to collaborate. So Kids Brain Health Plus is made up of three primary entities that all work towards improving the lives of children and youth with neurodisabilities and their families. So the Innovation Fund is really about building commercialization pathways to support startups, programs that have been effective and meaningful to support that implementation. The KBH network is fueled by the government and is around driving innovation, impact, spread, scale. And the foundation is powered by philanthropy and is really about increasing reach and access to more children and families across the country. And this is all done in partnership, such as these webinars with ChildBright. So I'll pass it over to Celia.
Yeah, so I'm pleased to be here today. I'm Celia. I am here representing as the co-lead for the training and capacity building with the Child Bright Group, which is really a network of more than 500 very passionate individuals that really want to focus on partnering and improving the lives for children and youth and their families with brain-based developmental disabilities. So next slide. So we really want to work together and learn together through all of these, and that led to part of the development around these webinars where we're trying to think about implementation science, how we can apply it, and how we can really support some of these changes that really aim to support brighter futures for children and youth. I think at this point we will pass over to our.
Yeah, thanks, Celia. Just some quick housekeeping here. Just very, very quickly, as a reminder, if you have any questions, reflections, you can put those in the chat. You can also use the Q&A function. If you would like to unmute, you can raise your hand and I can do that for you. So you have a chance to share verbally during our question and discussion. Dr. Crane said that you can share your questions kind of as they're going through her presentation, but we'll also have some opportunity for discussion towards the end. And now, again, for those who've been at these webinars before, you've seen this previously, and we just want to get a sense of who's in the room today and who's attending these webinars. And so I'm going to just quickly launch a poll. To share a little bit about your identities as you're comfortable with, and this is all anonymous, as well as your knowledge on today's topic. So I'll give everyone a moment there. And so, Margaret, so I won't share the results publicly, just around the identity-based data, but just so you can get a sense, Margaret, a few people are not at all knowledgeable, a few somewhat knowledgeable. We have pretty good range around knowledgeable to not at all knowledgeable, with most being around somewhat or kind of identifying as neutral knowledge level. Nobody extremely knowledgeable. All right. Thank you so much, everyone. And I will stop sharing and pass it over to our speaker.
Awesome. Well, I love hearing that folks come in with some level of knowledge. That will make for a really interesting discussion. If you have done any of this before, I'd also love to hear about your experiences. So just to introduce myself, I'm Dr. Margaret Crane. I'm an assistant professor at Brown University in our implementation science group. I'm also a clinical psychologist by training, where I work primarily with children. So today we're going to be talking about practical strategies for estimating the cost of implementation. I want to just share this QR code, and Vanessa, I think, will put a link in the chat. This includes my slides from today. I know I like taking notes directly on the slides. There's a lot of it text on the slides, so that might be easier for some folks. There's also a costing template and then a few key readings and references where you could learn more. So I'll just give you a moment in case you are scanning this QR code, and again, the link's in the chat. All right, I'm going to keep going. So just as a brief disclosure, this work was supported by the National Institute of Mental Health. The content is my own and does not represent the views of the NIH. Before I dive in, I want to just give you this encouragement, which is that you can do it. You don't have to be an economist to help estimate the cost of implementation. As I mentioned, I'm a clinical psychologist. I'm also an implementation scientist. I'm not an economist. And I just want to mention that before we dive in because costing can seem really intimidating, but really it's kind of basic math at the end of the day and estimating more time than it is necessarily money. If you're doing cost effectiveness analyses and other more complex analyses, that is when I would bring in a health economist. But just estimating how much an implementation effort costs, I think you can do that. And so hopefully after today, you'll feel a little more confident in being able to do so. Vanessa asked me to give this talk, and since then, this really amazing paper came out, which was great timing. in that this is a really wonderful guide on how to do implementation costing. I used this to even develop some of these slides because I think they laid it out so nicely. And I just want to encourage you to use this paper as a reference later on as well. Um, Andy Eisman, by the way, is someone who's very involved in implementation costing. So if you see her name, Lisa Saldana, Russ Glasgow on different resources, those are some big names. I'd imagine the others are too. I just haven't heard of them. That doesn't mean they're not fantastic, though. All right, so why does implementation costing matter? Um, I think, well, yes, if you're trying to scale a program and understand your costs as a business, that's important. But really, costing matters because, it impacts who we can actually implement these programs with. So cost is a very common barrier to implementation. And when I say cost, I mean both literal money, but also time. And that is because how people spend their time is actually a financial resource because people get paid. Um, or maybe they're doing it out of volunteer work, in which case that's an in-kind cost. Um, Costing helps decision makers understand the resources that they need to know where to invest their time, money, and staff as well. Um, and implementation is costly. So while cost effectiveness analyses can be really great, implementation efforts usually are often increase the cost of a program. That's because we're having people do more of something, or doing evidence-based interventions often require more resources, either materials, additional supervision and training. The training itself costs more. And so it's important that organizations understand what those costs look like so they know what they're committing to. Um, because sometimes there are hidden costs within time or, again, ongoing training. So if you're doing an initial training that's paid for, but a program requires ongoing supervision, that's something that organization needs to budget for. And so understanding these costs up front helps this work become more sustainable. Um, this all said, very few implementation studies report costs. And I think this is actually changing. We're seeing costs being included a lot in like an aim 3 of implementation studies, and that's because it's one of the most practical things we can tell people from our work. So I just want you to take a moment that you've seen implemented, and I'm curious if you know, or a program you're trying to implement. I'm curious if you know the actual costs, what it would cost an organization to run it or replicate it. I wish we could do a poll. I'm not going to, but just thinking a little bit about that, I would imagine the answer for most people is no, and that's why this sort of method is really useful. All right, so what counts as costs? So costs are all the resources needed to put a program into practice and to keep it running. So this often includes staff time. So that's both salaries and benefits. So it's not just someone's salary, but what's the cost that actually is required to support that person. Training and coaching, materials, equipment, technology. So some programs require you to buy manuals, for example. Others require you to have, different interactive tools that you might not already have. Space and overhead costs, both to deliver the program. Some programs also require like very specific space requirements. And then travel and coordination costs as well. So it's important to think about the difference between clinical costs, which is the cost to deliver a treatment to patients. So that's therapy sessions, medications, et cetera, versus implementation costs, which are the costs to get treatment adapted and running in the real setting. There is some debate within people who are involved in costs about whether clinical costs should be included. I tend to lean towards yes, because implementation can impact clinical costs. So, for example, if someone's implementing a treatment with high fidelity, sometimes that might actually increase the number of sessions a patient is involved in, which increase the cost of delivering a program. So, implementation and clinical costs are so embedded, I think they can be hard to tease out. Um, so again, I just want you to take a moment to think about what are typical implementation costs for your intervention. So thinking about these things on the left side of the screen, what might that include for your work? Okay, so for estimating costs of implementation, there are 4 basic steps you're going to do. The first is identifying resources needed, which we just discussed a little bit about. Then you're going to define activities. And so this is what your team actually does to implement the program. And so that's defining it in a lot of detail. And then you're going to measure the quantities. And so a lot of, again, I mentioned this, but a lot of what you're doing with costing is understanding how much time is involved. So a lot of this is just recording people's time or estimating time. And then assigning values to those resources. So understanding the time, how much does that actually equate to in dollar amounts, and then how do you report it? Um, all right, so for identifying resources, you're gonna really consider what does a new site need to implement this program. So I just discussed this a little bit on 2 slides ago. Um, but in thinking about what to include, it's also useful to understand who you're trying to present this information for and trying to get that perspective up front before you do any costing. Because based off who's paying is going to shape on what costs you're going to include. So most commonly, it's going to be the health system or clinic's perspective. So what are the costs to the organization deploying a program? That's most common because they're often the ones who are looking for grant funding to pay for this sort of implementation. You can also get the payer's perspective, so that could be government or insurance, and that is useful to understand on the budget impact of who's going to fund these services, what costs do they need to consider. Um, but you can also think about societal costs. This is probably less commonly done, but considering even things like family time, travel, lost work, when we're implementing new programs, the cost burden to patients is something that is often hidden from these sorts of analyses. So that might matter a lot for your particular program, in which case you'd want to consider costs beyond just staff time in a way that, while I'll be talking most about costs for, clinics and organizations, you might want to consider more of what does this cost for families? Because that might impact who can actually participate in these programs or what additional resources you might need to support these implementations. Um, so just taking a moment to think about who are the key perspectives of costs that matter most to your organizations and thinking about how you could get their feedback on what sorts of costs are important to them and how they might want to see this information presented. And again, doing that up front helps you be able to make this initiative as practical as possible. All right, the next step is defining implementation activities. And so in this stage, process frameworks like the EPIS or the SIC. So EPIS is exploration, preparation, implementation, and sustainment. It is a process model that also has determinants or barriers and facilitators within it. The SIC or stages of implementation is another process model. So process models of implementation walk through the different steps that might happen in different implementation phases. They're useful to reference because it then helps you really make sure that you're not forgetting anything. So thinking about the different steps of implementation, what are you doing at each of these steps? You can also use process maps. So that's, diagramming out how did this actually take place. So sometimes that can be useful to make sure you're not forgetting something. Um, and I want to encourage you to think about activities over a 3 to 5 year period. So, oftentimes, as well, when people start doing costing, they're in the middle of implementation or they've gotten the grant and they've actually already done a lot of pre-implementation activities. So, implement activities that happen before implementation. And if you can estimate those, that's really helpful because that's part of the overall cost of the program. If you are looking at costs within a research project, you're going to exclude activities that are specific to the research. So, participants completing research questionnaires, staff completing research questionnaires, because that's not going to be replicated if someone else is going to do that initiative outside a research project. Um, so, as you're defining different implementation activities, you want to ask who's involved in the activity, estimating how long it takes, what materials or equipment is needed at each stage, and how often it happens. And so, by estimating this out up front, first of all, it helps you actually plan for the implementation itself, but it also helps you make sure that you're not forgetting anything when you're doing the costing. So I like to think it kind of provides you a structured map of milestones. So this is using tracking activities using the SIC. And then the coins is costing implementation strategy. So the SIC and coins are done together. That's by Lisa Saldana. And so it then, once you've understood the different implementation activities you're doing, the coins tracks activity, personnel time, and cost at each stage of the SIC. And it considers both site-based costs, so clinic costs, and non-site-based costs. So could be the implementation team. Um, so the SICK is a really nice tool. It is not free though. If you have extra budget in your grant, it's fantastic. Lisa Saldana's team will help you as well with implementing it. I think it's like 3 grand or so though. So I don't think you need to use the SICK. And in fact, our team, maybe a little unofficially, has used the SICK just, I'll show you in a spreadsheet by mapping it out without formally using their web-based tool and their consultation resources. So again, this is just helpful because it looks at what are the different activities at each of these stages to make sure you're not forgetting anything. And again, it helps you plan for implementation as well. So here's what this can look like in practice. I know this is quite small. There's also a template included in that folder with a QR code. Um, I also just want to emphasize, as I screen share different ways this looks, there are many ways to do this. You do not have to use this template. You do not have to use this SIG. Again, there are other process models that you might find helpful. Um, this is just one way we've used it because I think sometimes it's useful to see how this actually ends up looking to help make it a little less intimidating. Because again, at the end of the day, this is often just kind of tracking things using spreadsheets. Um, so here we've listed out for the template each of the different stages of the SIC. You'll want to add rows if you have many activities within a phase, which you probably will. And so then you describe the activity. So that could be things like meeting to discuss potential programs, the people included. Um, and so that's helpful because you're going to then later on understand how much each person's salary is. And so you need to know who's included because then you can estimate their time. And then based off of their salary, you can then calculate the cost for that person being in that meeting. I also find after I do costing, I'm always very careful when I think about meetings because then you understand, oh, this meeting costs X amount of money, which we don't always necessarily think about when we schedule a meeting. Um, this again has site-based costs and non-site-based costs. This may or may not be a helpful column to differentiate. That can be useful though, because oftentimes the site-based costs might be more in-kind costs to the clinic. So those are not additional things they need to pay for, but that does impact the overall cost overall of implementing something. So you can say, of this implementation effort, we expect it's going to be $60,000. Of that, you know, 20,000 would be beyond what is just clinic time. So that's why you might want to differentiate it. But again, every project's different. And then we have notes column. So this could be, things that you're noticing, just anything you want to use for comments, maybe things you're going to come back to, etc. So here's an example of what this looks like filled out. So this is a project led by Dr. Justin Burke, who's at Brown, looking at hepatitis C prevention in a jail setting using minimal monitoring. So it's a very light touch intervention. Um, so the intervention is MinMod stands for minimal monitoring in jail settings. So you can see he has the activity. So it's engagement with leadership, assembling project team, again, who's involved, time per person. So sometimes you can also write out like how often it happens within this category. Site-based cost, so cost shared means that this isn't an additional fee. Um, and then non-site based costs. So there's no charge for this introductory meeting. Again, thinking though about what would it take to implement or replicate this, there might be a cost going forward rather than just being part of a research study. And then in the notes column, there's different assumptions regarding treatment that are going to then be useful for sensitivity analyses, which we'll discuss. All right, so then you're going to measure quantities. And we do this through activity-based costing. So this is identifying the cost for each activity based off the input it uses, which is usually with implementation just time. And so it's activity-based because we're literally tracking our time. And so within costs, we want to think about fixed costs. So these are one-time investments like planning time, equipment, that are going to be required regardless of your scale, because oftentimes when we think about costs, we're going to look at it with cost per patient served. And so these fixed costs are something that is going to be true regardless of how many people you serve. But then the more people you serve, the lower the cost per patient ends up being. And then variable costs, these are going to fluctuate and change based off the scale of implementation. So these are going to depend based off the number of sessions or the number of patients served. So variable costs are not necessarily going to decrease the more patients you serve because those are costs that are linked to the session time. So a lot of this is clinician time interacting with a patient. And then time-dependent costs are also useful to think about. And these are costs that occur over a fixed period, so quarterly supervision or other meetings. And for that, the scale of how much that costs is going to accumulate based off passage or time. And so basically, the longer you have this effort, the more of these time-dependent costs you might have, or the less it is if it's just something that happened once. And so this is useful just to consider because it impacts budgeting periods. I just wanted to also define these because when you're looking at costs, people, more economists are going to use these sorts of phrases. And so that's what they're talking about. Um, all right, so there's a bunch of different ways to measure activity-based costs. And so I'll talk through them, and which one you use is going to depend on, your initiative, what you think is going to be most feasible. It's often a balance between how much time it takes and so the burden essentially on getting that precise data versus having it be more accurate. So activity logs, I'd say this is the most common way I see people doing costing. Um, there can be some recall issues, but so essentially staff record the time they spent on each implementation tasks. Um, One thing I found interesting is there's some research that suggests that past recall tend to overestimate costs. And so this is to me an incentive to try and keep up with this on an ongoing basis because you don't want to overestimate how much your program costs to implement because that might scare people away. And if you're looking back on the past 6 months, people actually tend to overestimate how much time they spent, which I found interesting and surprising. Um, for activity-based logs, ideally you're doing this every single week on a very ongoing basis. That's the most rigorous way to do it. Um, that's not always feasible though. And so sometimes you can have staff track their activities perhaps for a 2 week period and then extrapolate that if, they're doing ongoing just clinical sessions. If there's the same activities done week to week. Really, I want you just to consider what's feasible, again, knowing that there's going to be trade-offs between accuracy and burden. Um, Activity logs, you can also use time cards for these. That's really helpful. I do want to just caution for time logs that sometimes, for example, in a research-based project, you might hire a community health worker and they might worry that if they're really accurately recording their time, let's say you've hired them to be paid part-time and they're in fact working a little less than that, which is fine with you. Like you're totally fine with that. You're like, I know I needed to hire you part-time. So just discussing, especially if you're using time cards or if there's a mismatch, that what we're doing to measure time is different than how we're paying you. And we want you to be really accurate so we can scale this. Um, but I just wanted to mention that because that's sometimes something that comes up that can be sensitive and can sometimes lead costs to be inflated when, we want them to actually accurately report how much it costs. Sometimes that's also why it's helpful to have an external person doing more costing. I know I'm meeting separately with a community health worker on a study to discuss costs so that then they feel like they can more accurately report things. Um, all right, direct observation. So this is a very precise way of measuring costs, but burdensome, so I see it less, which is where a research team watches and records what staff do. Um, Questionnaires, this is lower burden. It's often less precise, where staff complete surveys about cumulative time they've spent on things. The more frequently you ask for these surveys to happen, that starts being more like an activity log. Um, the more accurate they are. But so questionnaires is like, looking retrospectively, how long did you take? Interviews, and this is trained staff interview key people about time and resources. I would recommend this in addition to even if you're doing activity logs because it adds really nice context that can help understand the context that may impact different costs. You can also use EHR as a database. So some administrative records can capture time automatically, which is really cool. So you can see like how long is someone spending within a given session. That though requires infrastructure or people who know how to pull that sort of data. I want you just to think about which of these methods might work best in your given context or for your project. Um, so then here's a template of how this actually looks. And so you're going to essentially copy the 6 stages. If this is again using the SICK. Again, you don't have to use the SICK. But you're going to copy the projected activities you do and then have date completed or dates, hours it took, site personnel and description or notes within this. Sometimes this might be a date range or this might be like 3 hours per week. If you're listing it like that later on, you're just going to have to reformat the data so that you can calculate the actual, dollars per each of the activities. But so that's how we did this in this study again. We looked at how many hours each of these things took, over a period of time. So some of these had dates, and then later on it was kind of more by month. And so then you want to list the different sites and then the staff there. And usually you'll list the name, and that then again helps you calculate their salaries later on. Um, Okay, and then the next step is turning these resources of time into dollars. And so essentially, this is just where it's like simple algebra in many ways. This does require often a decent amount of data wrangling just because it's easier to track costs with many people involved. But then you'll need to, what I often do is have like one column per staff member and then like have a formula to kind of multiply out the costs. But I haven't included that template because this looks so different for every study of how this actually ends up being calculated. But, there's just, again, some amount of data wrangling. So basically you just multiply personnel time times their wage, which is their wage plus fringe benefits. You can do this with actual wages. This is more precise for your specific project, but it's less generalizable to other sites. Also, some organizations might not disclose staff wages, externally, but this is really useful for internal planning. So if you're wanting to see about implementation within your organization, let's say there's many clinics, using actual wages makes probably the most sense. More commonly, if you're reporting these externally, you're going to use like a Bureau of Labor Statistics wages. So there's free publicly available databases. I think the one in Canada, I haven't used this one, but is Job Bank, where you can search what wages might be for a given occupation and region. It's best for comparing across studies, and then usually we say add 20 to 30% for fringe benefits. I don't know if Canada has specific fringe benefits that's a standard amount to include. But again, you can think about what you're including and just you note it because it might, if you're including more or less for fringe benefits, that might vary based off of other organizations. So just as a very, very simple example of what this might look like for, parent coaching training for therapists, let's say with, for a program where parents of children with autism are getting additional intervention support. So maybe there's an initial training. This was done with occupational therapists in this example. That training took 16 hours each. Again, these are made up numbers, but their rate is $55 an hour, including fringe. And so the cost of that training is $4,400. Program materials and resources, this is just looking at a specific training. So, it's staff rather than looking at resources, but you could see maybe these programs or resources is $200 for this specific program. And then there's an external facilitator. That required 8 hours. This math doesn't quite line up in this example. I should edit this slide. But again, you're looking at, how much does that trainer costs? So again, it's just basic math at the end of the day. So this is why you can do it. Um, so then the other thing you want to think about is planning for replication and sustainment. So for scaling up, you want to think about what it might look like within similar systems with higher volume. So this is where then the analyses get a little more complex, but again, you can still do it. But you then start having kind of hypothetical situations. So these are what we call like sensitivity analyses. So what are the fixed costs that might spread across participants, but then the variable costs might grow. So thinking about as we scale this up, how might these costs change? Scaling out to new settings or population, rural clinics, different disability types, these costs might vary significantly depending on, like transportation costs or something like that. And you could also do sensitivity analyses. So you can kind of, when I say model, again, it's just calculating different costs for best and worst case scenarios. So you could look at higher or lower wages. So let's say we want to hire a community health worker versus a licensed psychologist. Those are going to be very different wages, so that would impact the costs. Or, you can estimate with minimal or more implementation supports. How might that estimate the costs? And this helps you show like a realistic range of how much these programs might cost. Within sensitivity analyses, you can also look at it. So in this example here, we did the sensitivity analysis. This was a group-based program that looked at a lot of different things based off of different models of running this group. So this looked at cost per patient encounter. It's dyad here because this was a weight loss program that included both parents and their children, so the parent-child dyad. And so model one was the actual trial, and you can see that was the most expensive. That included things like actual attendance, included different personnel categories. And so this was more expensive because they ran groups separately. And so there was more drop off when they ran a group program if some parents didn't attend some programs or they had to wait for full enrollment. So they had staff time that wasn't like maximized. Model 2 looked at full cohorts. So this assumed that the groups, so there were 8 dyads, so 8 different families in this group program. If it was done over a rolling period, you could maximize how many people were in this. And so that then helps spread those fixed delivery costs over more families. So you can see those costs go down. And that's helpful for implementation because the clinic can think about if I want to implement it using rolling group admission to this treatment, that will then decrease our costs because we'll be able to serve more families, charge for more fee for service of these groups, and that will help us make this a more financially sustainable option. Then they had this turnkey package, and so this is kind of what they expect going forward. So within this implementation effort, they did a lot of initial adaptations. But so the turnkey packages, if you're not going to be working with the implementation team to make adaptations, if you're just going to kind of take it as it is, it's a lot cheaper. And so, for some clinics that might be beneficial. For other clinics, though, they might say, no, we want to have that more personalized tailoring. Um, so I want you, and by the way, the lead author of this is Katie Darling. Elisa Jollian is the primary investigator on this grant, and this paper is under review. So I just want you to think about what sorts of sensitivity analyses might matter for your program. And so for this, in this paper, we reported all 3 of these costs, but thinking about what sorts of different things might you want to estimate. All right, next is how you're actually going to report the costs. And the basic thing of this is you want to report it in ways that are clear and useful to the people making decisions. So this is where it's useful to have those people's perspectives from the beginning because that helps you know what sorts of costs you're going to report. Um, and you want to clearly state your perspective of like who's paying, and you can think about here, these are costs more for the clinic is the perspective we're thinking about based off patient encounter. They can then consider based off the billing rates, is this going to be financially sustainable for us? Um, so personnel costs are really useful to report. That's who, what role, how much time. This is the largest impact on cost driver. It's also useful though to separate that out because as I mentioned, a clinic might say, hey, we're already paying staff, so we're just going to have them do a few things extra, but like well, yes, that is what the program costs. That's less of actually a cost burden on us. Cost by phase, so pre-implementation, implementation, sustainment. That's useful because that helps organizations budget and understand what sorts of grant support they might need. So while we might need X amount upfront, and if we're getting a grant to do implementation, the pre-implementation is going to be in-kind cost from the clinic. And so again, it's helping them understand what sorts of impacts there might be from the get-go. Because oftentimes when you're doing pre-implementation, you're deciding whether to implement a program, but that takes time, which therefore costs money. So again, just helping them understand a little bit about costs of as you're deciding this is, there is a cost associated with that. Per unit cost, so that can be, it depends on what you want to look at for your program. So that could be cost per client served, per therapist trained, per site. Again, this is where this is simpler math because you literally just divide the cost by whatever these numbers are versus cost effectiveness is much more complicated. And then you also want to report the total cost, the total cost of implementation. And again, that bottom line is something that as you're talking to a lot of decision makers, that's the number they want to know. Because while they might be able to budget for it, they need to know what they're budgeting for. Um, and so, as I was talking through the last few slides, there's a lot of different assumptions we make within these cost models. So you just want to report all those assumptions, what's excluded. If there are certain activities that you weren't considering, so you could say this was conducted as part of a research study. We're excluding the costs that are specific to research, like completing questionnaires. And then, ideally, in addition, if you're publishing it, also having like a 1 to 2 pager with tables, clear conclusions that you can easily share with partners. While noting major factors that could change your estimates or sensitivity analyses. So, noting again, for this past example, if you have full groups, that does change the cost per encounter quite a bit. It can also be useful to contextualize costs. And so within this study, this was compared, there's a bunch of different CDC weight loss programs. And so thinking about what are these costs compared to alternatives you might be considering. And you can see, well, it's useful to contextualize these costs because in the abstract, it's not necessarily always so clear, like, is this expensive? Is this cheap? And so this helps you understand based off of other programs they might be considering, what might this cost? If you are on the more expensive side, why is it then worth it to do that more expensive program? Um, and so again, these are just costs, I think, per patient, yeah, per family. And what you're going to be doing is the comparison. Again, that's where you want to ask your partners of what sorts of costs matter most as far as what data to present. I just want to put in a quick plug towards mixed methods approaches for economic evaluations. That wasn't the focus of this talk, but as I mentioned, doing qualitative interviews in addition to just getting the raw cost numbers is really useful within implementation. Like all qualitative or mixed methods approaches, it helps provide more rich data. That's helpful though also for doing things like sensitivity analyses. It's helpful understanding the sources of uncertainty or what factors might impact costs. So, like within more modeling equations, the error term is often that kind of uncertainty of what might vary from organization to organization. So you can understand like the error in the costing model through these more qualitative approaches. So I'd encourage you to add in some qualitative or mixed methods approaching when doing costing because it will help you do your costing better, but it also provides really useful data in moving the implementation forward. All right, so some common pitfalls that we might see within costing analyses. One is missing indirect costs. And so that's a problem because that underestimates costs by like 30% per staff time. It's a lot. Um, Sometimes people don't do sensitivity analyses. And so, again, it's really useful to run the best and worst case scenarios to acknowledge uncertainty. It also just, again, helps contextualize costs. Um, Forgetting sustainment. So oftentimes I've seen costing done within the implementation trial, in which case the implementation phase is really the only phase being captured. And that misses both implementation costs and also sustainment costs that an organization might have to bear after a grant ends. I know at least in the US, I'm not sure if this is the same in Canada, grants often fund initial implementation but don't cover those ongoing sustainment costs. And so that's helpful. For an organization to know what sorts of costs they're going to have to bear later on to help the program be more sustainable. And then I'd say the other really common thing that we see is starting late. And so I really would encourage tracking costs from day one. Retrospective data is just less reliable. Again, as I was mentioning, understanding costs also helps you plan for implementation if you're mapping out the activities for each phase. If you are starting late, that's okay. I've been involved in a few different costing studies where they've already started implementation. Just, understanding that's a limitation to your cost analysis. All right, so I mentioned that you can do this. There are times though when economists and health economists are going to be helpful. So things that are doable without economists, basic cost analysis, so like time times wages, activity mapping, tracking staff logs, tracking staff times with activity logs, reporting totals and per cost unit, also feasibility or ballpark estimates of, those different scenarios. So basically, most of what I talked about, I think you can do without an economist. Economists are great though also, and they add really valuable perspectives. So yes, of course, if you have the time to pay one, it can be really helpful. Um, if you're doing cost effectiveness or cost benefit analyses, those are a lot more complicated. More formal sensitivity or scenario analyses, again, that involves a lot more statistics than math. Um, as I mentioned, economists are helpful in helping evaluate societal and equity impacts. They just think differently than those who are not economists do, which I think can be helpful in, thinking about things you might have missed. It's also going to be helpful for preparing evidence for policy decisions. Again, a lot of policymakers think a little more like economists, and so sometimes it can be helpful to have that perspective again of things that I wouldn't even think that I don't know about. So economists are great, and I don't think you necessarily need them. All right, so just as some practical tools to get you started. So again, the Sick Coins has a web-based tool, and that helps you record costs as you go. There's a costing guidebook. I'm pretty sure this is in the folder that I attached, which it has downloadable guides, spreadsheets, interview guides. It's really long, but if you want to do a really deep dive, by all means. Wage data, again, here's the link to the one in Canada. I'm pretty sure. I haven't done research in Canada, but which are free public databases with wages, and you'll use those to estimate the salary cost. And then the Eisman paper that I've been referencing throughout this. Again, it's a really wonderful practical paper. that really grounded this presentation and how I was describing things. Um, all right, so I'm going to take some time for questions. I see there's also comments in the chat, which is great. And then Vanessa also asked me to help you all. We could also have more of a discussion as well of like thinking about what typical costs or implementation are for your interventions, who are the key conformants you'd like to consult, what methods you might use for activity-based costing, and then what sensitivity analyses you might want to consider.
Thank you so much, Margaret. This has been so fantastic. And yeah, we can pose those questions if people wanted to reflect in the chat around, have you done any cost analysis, cost tracking? What are some of those key activities? Margaret, I have found this so helpful in like really thinking about those details and like again those detailed activities and like your point, and there was another reflection in the chat by Kate just around the like great like meetings, like come join this meeting, let's talk it through, how many people are there, what cost is that to the organization. This has been so practical, and someone who this like just goes right over my head. I feel like I actually have a grasp of it. So just really thank you for taking the time to tailor that and make it very practical and useful for our group today. So yeah, everyone, please share your reflections in the chat if there's anything you would like to add, and any questions. I know I have questions, so happy to kick it off. And Celia, if you have any questions as well.
Yeah. And I'll also just reflect when I started doing this as well, I was a little overwhelmed and intimidated, but a lot of this you just figure out as you go. Again, most of this is just tracking the time spent, the resources involved, um, how to actually do that. You also need to figure out a little bit for each project anyways. So there's not like a gold standard if you do, don't do it this way, you're doing it wrong. You're figuring out what does this look like for your specific project.
Exactly. Thank you. So, can I ask a question first? So, kicking it off also, and I loved the bringing in of qualitative because definitely more of a qualitative researcher. So, I appreciate that piece around bringing in that important context. My question, or first question, when you're going through this around things like activity logs and tracking time and tasks. Um, have you found, so, or I guess who typically does that? Is that someone from your team who supports the clinic or organization that you're working with? Is that someone on the front lines doing it in real time tracking? And have you had hesitancy towards doing that? Or, yeah, just from a practical perspective.
Yeah, absolutely. This is where I think the question about like burden versus accuracy really comes in
Mhm.
and is something to just discuss with the whole team because if people don't have buy-in to do a more burdensome method, they're just not going to do it and the data is not going to be accurate. So understanding like what your team is on board and excited about can be really useful. And even before doing that, taking a step back to say like, we're trying this new thing that's so awesome that other people might want to replicate. To do that, they need to know how much it costs. And so, one of the biggest learnings we can give from people is about cost. And to do that, though, we need to know how much time you're spending on it. So really helping them understand the rationale of why you're asking them to complete like time logs all the time, which are very boring to complete, can be helpful. Um, in practice, just to give an example, I feel like it's often more of someone who's on the study team who does this. So let me go back over here. Like Justin Burke was the one who completed all these meetings. I think he was a part of most of the meetings though, so he could do that.
Okay.
Um, that's not always going to be the case. And so as far as who's completing it, you need to know who knows what people are doing. And then again, in this study, we then met with the community health workers separately to ask them like what other costs are involved from your end that we might not be thinking about, to then get their perspective separately too. And a lot of those costs are more ongoing costs. And so, what I often do for that is have people track their costs for like a week or two to get like an
Mm,
average week.
yeah,
There's never
I
an
like that.
average week. People are always like, oh, but this happened, but like that always happens.
Yeah.
Um, and so, but if it is ever a really weird week, then say, yes, okay, do it a different week too. But so again, a lot of figuring out how to do the activity-based monitoring is just what feels practical to staff. You know, I think a lot of us have pretty accurate calendars nowadays. If not, I am very impressed with how you organize your life. But people will go back to their calendars and just, literally look at and add up the meeting time. Maybe scaling or adding like an extra half hour if they know they're doing prep or follow up before or after meetings. And again, that's where if there are ongoing things, tracking it for a week or two can can help it be more feasible because then you can understand it better. Another tool I didn't have in here is, um, there are various ways to help people track their times. I personally like this tool called Toggle Track, Toggl. You don't
Hmm.
have to use that. It's just a timer. But I mean, I found that useful for myself as I've tried to focus. But and so I've used it in projects too. If anyone has timesheets, that's also really, if people have to clock in and out, those times are actually quite accurate then. Um, so if you can use people clocking in and out if they're only working on one project, that's great.
Perfect. Yeah, those are really helpful insights and tips. Thank you, Margaret. I know Corey had his hand up, but I know I just saw you put something in the chat, and Genevieve also has their hand up. So I'll unmute you there, Genevieve.
Perfect. Thanks so much, Vanessa. Um, Thank you also, Margaret, for a great presentation, super helpful. I was just curious for projects, for example, where you might be implementing across like multiple different settings. I feel like oftentimes the first time you do it is a bit more like cumbersome, or there might be more costs associated compared to when you actually start doing it, maybe for the fifth time or the 10th time, depending on the program. I was just wondering if there's a way that you recommend sort of like teasing that apart so that you don't overestimate the cost of implementation if, for example, someone's coming in as like the last group doing it versus the first group.
Yeah, I think that's a really great point. And that's also thinking about like who's going to use this cost data. Like if it's the same team implementing it again and again, they're going to get better and faster, as you just mentioned. So that is a little bit what this turnkey package looks like. So that's a great thing to do is like a sensitivity analysis. So you could say, here's the actual trial. Here's what we then expect going forward. So, some of these things we expect going forward based off of this to be estimated in this way. And you just want to state your assumptions of like why you think it's going to be faster. But I think that's absolutely often true. And, I'd imagine this number here probably is going to be one of the more helpful things when they're trying to talk to organizations who want to implement this program because most of them are probably going to take more of that turnkey package. If you are an organization that is trying to scale implementation of like, a specific evidence-based practice, so if you started a purveyor organization, say, it's also useful to estimate costs over time and continue to update the numbers. So, as you mentioned, the first time you do something, it's going to take a lot longer. And so that might not be the number you want to report to new people. And, then thinking about, okay, we've gotten better at this. So, we're not hiding anything. We're better at this. So it's faster. So it's going to be cheaper. Just to summarize, I think that's where these sensitivity analyses can come in.
Perfect. Thank you so much.
Yeah.
Thanks, Genevieve. That was a great question. Um, I see a question from Corey, or a couple thoughts from Corey in the chat there. Um, Corey, I can unmute you if that's easier.
Hello. Sure, I can ask my questions, but I this was fantastic first and foremost. So really appreciate you sharing all that information. I was just trying to think about kind of two things. One was, as I put in the chat, kind of a lot of our implementation work. I know, kind of actually getting a dialed in cost. Sometimes we are not part of that 7% or 7.8% that's done this work up front. And so I was also just wondering how much having a costed implementation program actually improves the uptake of implementation at that readiness point. So I was wondering if there's any, knowledge around that, just because I thought it might be interesting. And my gut says probably partners are more likely, but I'm just wondering if you have any insights. And then I was also thinking about the sustainment cost after the initial kind of implementation funding kind of may lapse, and was broadly thinking about, is that work that needs to be kind of done ongoing? Is that work that's often quite reliable based on the initial implementation piece? Is kind of what level of accuracy do we usually get from kind of that sustainment costing? And again, just kind of more broadly, rather than, brilliant questions. They're more just things I'm kind of noodling on and wondering if you have any thoughts about that.
Yeah, these are great questions. I'll also just say, by the way, too, if other things come up as people keep noodling, feel free to email me later too. Um, so, the first question is like, how much does cost help with implementation? I would defer to your own experiences of that as well. I know for me, when I've been involved in implementing new programs, often key decision makers are asking, how much is this going to cost? And so I think having that answer be rather than being like, oh, I don't know, is really helpful. I also think too, the more accurate we can be about costs, the better partner we're being. If we just say, oh, it costs this, but then there's all this time that we didn't predict, that then might leave people a little grumpy and less on board with implementation. So I think it's really useful for people to know what they're getting into before they commit to something. Also, as well, as we scale these programs, oftentimes these costs are going to be covered by grants, and so people need to know what to budget for. Um, so those are some reasons why I would encourage costing to be done as much as we can, because in the real world, that is unfortunately a factor. And even if the costs are just time, it's useful for clinics to know how their staff time is going to be spent. Um, as far as sustainment costing goes, so one thing to think about is I think it's useful to estimate costs within a 3 to 5 year period, and how long you're looking at costs is going to depend on the program. That's the recommendation that's given in part just because that's what people often are budgeting for. Um, so like within budget timelines, or a grant funding period is often 3 to 5 years. Um, as far as what changes in the sustainment period, I would again think about your specific program, also what organization you're implementing it in, like how much is required on an ongoing basis. In some organizations, there's a lot of staff turnover, in which case, in the sustainability period, there's actually a lot of ongoing costs. So I guess I don't have like a fixed answer for that, but that's probably true with a lot of implementation costing. It depends on the setting and the program. Um, but estimating it for like 6 months to a year. But even that isn't a set guideline. It depends on your program.
Yeah, that was very helpful. Thank
Yeah, and all questions that I have about sustainability and scale and all of those things. For some of the people on this call in particular, I believe that some of them is more when it's still in that mix of research and implementation. And some of those tasks that they're doing are the research side that wouldn't necessarily be part of the next program. So how do you encourage people to kind of tease that apart a little bit when some of those things are not something that would be in that turnkey package, but you still need to do it and it's still like how do you kind of distinguish some of those different pieces for research versus actual implementation of the program?
Absolutely. So this is also where asking your team what makes sense works. So within the SIC, they have, I think, a button that's like research only or exclude, or there's some way you can track everything, but then differentiate it and later exclude it from analyses. I know that people I've worked with more, whenever I'm like, you don't have to track that, they're like, fantastic, I'm not going to. But so, really deciding when you're thinking about what are all the activities we're doing, sometimes it's useful to list the research activities and then say, we're not going to track this. If it's easier for your team to just track everything and not, consider and differentiate until later, that's fine too. So that's, I think, a preference of what's easier to track, but definitely wanting to make sure to take out the research components. This said, a lot of implementation efforts have, ongoing evaluation and measurement. And so, trying to estimate, well, yeah, some of this is research, but in fact, we're going to expect people to do ongoing evaluation and measurement. They're going to need to do that for grants and, to make sure that they know what that costs. That could be, a separate line item, for example, of like, here's what we might estimate this could take to evaluate this, if that's something you want to do, because not everyone does.
Yeah, and really that even that conversation about what's research and what is the program is a really valuable one to be able to know what's there. And if somebody else were to do it, what would be those key pieces? And that monitoring and evaluation is one that always gets treated as research, but it's actually part of the whole thing to be able to know if it's still working from the sustainability side. So all great points. Thank you.
Yeah.
All right. Great question, Celia, and thank you, Margaret. This has been excellent discussion. Can pass it back to you. I don't know if you have some key takeaways you wanted to go through there, but yeah.
Sure. I realized I skipped over this slide at first, but my key takeaways for you all is just that It is feasible to do implementation costing without an economist. Um, Activity-based costing is really the foundation of this. You're going to define activities, measuring time, assign dollar amounts. Process frameworks like the Sick and Coins can help you track activities across implementation stages. You're going to report costs by phase, activity, personnel, patient, plan for replication about what you're going to need to replicate this in another site. Um, and then, yeah, costing work helps others budget to replicate your efforts. So thank you for the time. And if you do have other questions, feel free to contact me. And thank you for the invitation to speak with you all.
Thank you so much, Margaret. Again, this was fantastic. So many great learnings, so many, you can see the compliments in the chat and how this content has really resonated and very, very practical. So thank you. This recording will be on our KBH implementation community webpage. I just see that question in the chat there. And we will be taking a pause for the summer months here in Canada, July, August. And we will see you all back in September. Thank you again, Margaret. Really, really appreciate it.
My pleasure. Great
Thanks,
speaking with you
everyone.
all.
Bye.